It's a
Namaskar, dear viewers. Welcome to today's critical care session. So today we have the international faculty webinar, and it's a great honor and pleasure to have with us Dr. Jozwiak Mathieu. So Dr. Jozwiak Mathieu has been very kind to take another lecture for us. Last year he had talked on vasopressors, which is there on a YouTube channel, and many of you have gone through it and appreciated it. So today the topic is inotropic drugs. And with that, we'll be covering cardiovascular pharmacology in some detail because we talked about vasopressors and now inotropic drugs. So Dr. Jozwiak Mathieu is a full professor in intensive care and he works at the Medical Intensive Care Unit, Nice Teaching Hospital, France. And his research area is cardiovascular dynamics. And he has more than 100 publications, including research papers, that is, original research papers, book chapters, and so on and so forth. So we are indeed fortunate to have him with us and hear from him. Thank you, Dr. Joswick, so much, and please over to you.
good evening, everyone. Thank you very much for this invitation. I'm delighted to be with you for the next hour, and we are going to discuss about a very important topic. You are right. We discussed about vasopressors last year, and right now we are going to discuss about inotropic drugs. So here are my conflicts of interest. And inotropic drugs is a very vast topic, so we have to focus on specific situations. And in my mind, when we want to discuss about inotropes, we have to select two different situations. And the first one, of course, will be the cardiogenic shock, because it's clear for everyone that if there is a decrease in right ventricular or left ventricular contractility, we have to consider the use of inotropes in such patients. So, what about cardiogenic shock? The first important thing to have in mind is that there is a clinical classification of cardiogenic shock, and right now this is a continuum because between patients at risk to develop cardiogenic shock but without any symptoms of cardiogenic shock. This is the A rank to the E rank, which is the most severe rank, and which represents the most severe patients, meaning patients with cardiac arrest. And in this lecture, we are going to discuss about the C rank, meaning C for classic, the classic cardiogenic shock. It is a patient that manifests with hypoperfusion that requires intervention. And among intervention, we are going to discuss about inotropes. And there is also a hemodynamic classification of cardiogenic shock, and we are going to discuss about the classic cardiogenic shock form, meaning patients who had low cardiac index or low cardiac output, high systemic vascular resistance because of the peripheral vasoconstriction, and congestion, venous congestion and arterial congestion, and especially with elevated pulmonary capillary wedge pressure. What about the pathophysiology of cardiogenic shock? As I said a few minutes ago, this is right now a continuum from patients at risk to patients with cardiac arrest. And of course, we are going to see macro hemodynamic disorders and venous congestion. And the more severe the patients, the more marked the congestion and hypoperfusion. And besides macro hemodynamic disorders, there are also microcirculation disorders with arteriovenous shunts. And the combination of macro hemodynamic disorders and microcirculation disorders will lead to systemic inflammation and therefore to organ dysfunction. And if we are not able to stop the development of cardiogenic shock, so the patients will develop multiple organ failure and therefore will die. And regarding this pathophysiology, we can understand why it is needed, it is required to administer not only inotropes but also vasopressors to patients with cardiogenic shock. This is because of this systemic inflammation, which will induce macrohemodynamic disorders similar to those we can see in vasoplegic shock in patients with septic shock, meaning a marked vasoplegia. What about the recommendations for the management of patients with cardiogenic shock? There are many international guidelines. There are European guidelines. Most recent are the 2021 European guidelines. There are also Indian guidelines from 2018, and both guidelines are very, very similar. So when we look more precisely at these guidelines about inotropes, inotropic agents may be considered in patients with systolic blood pressure below 90 millimeters of mercury and evidence of hypoperfusion who do not respond to standard treatment. Right. Which inotropes should be administered. And in these European guidelines, there are a lot of inotrope drugs that are recommended. And the first point is that among inotropic drugs, there is norepinephrine. And when we look also at the recommendation regarding the vasopressor therapy, what is indicated is that a vasopressor, preferably norepinephrine as a first-line vasopressor. So what we can see is that norepinephrine is considered both as a vasopressor but also as an inotrope drug in these recommendations. And what is the feeling of intensivists? And this is the results of a very interesting international survey endorsed by the ESICM, meaning the European Society of Intensive Care Medicine. So more than 800 intensivists from 82 countries responded to this survey, international survey. And the question was, which inotropic agent do you recommend to be used in clinical practice? And what is very interesting is that norepinephrine was considered as an inotropic agent by more than 60% of respondents, meaning that more than 60% of respondents know that norepinephrine is not only a vasopressor, but also a drug with inotrope property. And for sure, norepinephrine should be the first-line vasopressor considered for all types of shocks, so including cardiogenic shock, because norepinephrine has many, many very interesting physiological and clinical properties. First, norepinephrine increases cardiac preload by increasing the systemic venous return. Second, norepinephrine improves coronary perfusion, and more precisely, norepinephrine improves the left coronary perfusion. Third, norepinephrine increases cardiac contractility, and it has been very nicely demonstrated in many physiological studies, including patients with septic shock. And when the authors assessed the effects of noradrenaline on cardiac contractility, they observed that norepinephrine administration increased left ventricular contractility, as illustrated by the increase in left ventricular ejection fraction, increase in subaortic VTI, and increase in mitral S wave. But that was also true for the right ventricle, with an increase in the tricuspid S wave and an increase in TAPSE. So to summarize, norepinephrine is able to increase the left ventricular and the right ventricular contractility through its beta-1 effect. And finally, norepinephrine also improves muscle tissue oxygenation. Overall, norepinephrine has many, many beneficial effects, cardiovascular effects. And norepinephrine cannot be considered as a pure vasopressor, but should be considered as an inopressor, meaning an agent which has a vasopressor plus an inotrope activities. And the reason why, when you consider norepinephrine as a first-line vasopressor agent in patients with cardiogenic shock, this is very interesting because you can counteract the vasoplegia induced by the systemic inflammation, right? But you can also partly correct the inotrope deficiency. What about the other available inotropes? The first one is dobutamine, and for sure, dobutamine is the first line inotrope agent considered by clinicians. Here we come back to the survey endorsed by the ESICM, and as you can see, dobutamine is considered as an inotropic agent by more than 90% of respondents. And everyone knows that dobutamine, through its beta 1 effect, is the most potent, the most efficient inotrope agent. But we have a price to pay when we want to use dobutamine because of its beta 1 but also beta 2 effects. Side effects are tachycardia, hypotension because of excessive vasodilation. And that's the reason why I think that in patients with real cardiogenic shock, this is not really a problem to know if we have to start with norepinephrine or with dobutamine administration. When you want to increase the mean arterial pressure level, you have to administer first norepinephrine as a vasopressor. But the inotropic effect of norepinephrine is not enough efficient to be able to counteract the inotropic deficiency. So you have to add dobutamine in a second as a second line. And if you want to start with dobutamine administration, so for sure you will correct the inotropic deficiency, but because of the excessive vasodilation and arterial hypotension induced by dobutamine, you will have to administer norepinephrine in a second time. So patients with real cardiogenic shock require norepinephrine plus dobutamine administration. Just a focus on a very important physiological point in my mind. This is the complex graphic in which the x-axis is oxygen supply, DO2. The left y-axis is VO2, so oxygen consumption, and the right y-axis is the peripheral extraction of oxygen, AO2. And what I want to illustrate with this graph is what happens when, in terms of oxygen consumption, VO2, when DO2 is decreasing. In the first step, when DO2 is decreasing, you can observe that VO2 remains constant. Why? Because of the increase in peripheral oxygen extraction. And for sure, if DO2 decreases below a critical threshold, the critical DO2 value, peripheral oxygen extraction cannot be increased anymore, and we can observe a decrease in oxygen consumption, and signs of tisular hypoxia will appear with hyperlactatemia. So for sure, we cannot calculate the peripheral oxygen extraction at the bedside, but we can also measure the venous oxygen saturation, or the central venous oxygen saturation, which is a good surrogate of peripheral oxygen extraction. What happens in terms of SVO2 when DO2 is decreasing? As the first step, so we will observe a decrease in SVO2, which just illustrates the increase in peripheral oxygen extraction. And if DO2 decreases below the critical DO2, so SVO2 will remain unchanged because peripheral extraction cannot increase. In other words, SVO2 reflects the adequacy between oxygen supply and needs. And when we administer dobutamine to our patients with cardiogenic shock, we have to measure for sure to monitor SVO2 or SCVO2 before and just after the administration of dobutamine. And sometimes we can see that dobutamine increases cardiac output of patients, but does not increase in a large extent SVO2. For example, SVO2 may increase from 45 or 48% to 50, 55%. What does it mean? Should I stop dobutamine in such patients? I do not think so. I think that when the SVO2 does not increase in a large extent when you administer dobutamine, it only means that for sure you increase the cardiac index of your patient, you increase the oxygen delivery of patient, but you do not sufficiently increase the oxygen delivery of patient, meaning that there is a dependency between DO2 and VO2, and the first thing cells are doing is to reimburse the oxygen depth before decreasing the peripheral extraction. So if SVO2 does not increase enough after dobutamine administration, you have to consider to increase the doses of dobutamine to increase in a large extent DO2 and therefore to reach the plateau in this curve, meaning the independency between DO2 and VO2. What about other inotropes? The second one in this list is dopamine. I don't know if you still use dopamine in India, but in Europe, no one is still using dopamine. And if we ask about this, the different intensivists in Europe, as you can say, more than 90% of intensivists do not consider dopamine as an inotropic agent. Why? Because of this big study, this multi-center randomized study from Daniel Debacker and al., the SOAP study. In this study, as you can see, more than 1,700 patients with shock were included, represented 16% of patients with cardiogenic shock, and norepinephrine was compared to dopamine as first-line catecholaminergic agent. The primary endpoint was 28 mortality, and there was no difference in both groups of patients. But if we look at the subgroup analysis in this trial, we can see in the subgroup of patients with cardiogenic shock that dopamine use was associated with higher mortality rate. And more generally, in the population, the use of dopamine was associated with a higher risk of cardiac side effects and of cardiac arrhythmia such as atrial fibrillation. And for sure, the since this SOAP2 study, dopamine is no longer recommended in Europe as an inotropic and even as a vasopressor agent. So let's back to the list of inotropes. Dobutamine, dopamine, norepinephrine. The fourth one is epinephrine. What about epinephrine? As you can see, when we look at the results of this survey, 50% of responders are using epinephrine as inotropic agent, but 50% of respondents do not consider epinephrine as inotropic agent. What are the reasons not to consider epinephrine as an inotropic agent? Because there is a fear about worse patient outcome with epinephrine compared to norepinephrine plus dobutamine. There is fear about decrease in regional blood flow and especially the splanchnic circulation with the use of epinephrine, and because epinephrine use may be associated with an increase in blood lactate level and an increased risk in cardiac arrhythmias. So, what about epinephrine? The first point is that you can see that epinephrine and norepinephrine structures are very similar because epinephrine comes from norepinephrine. That's the reason why epinephrine and norepinephrine have similar vasopressor effect. But the main difference between the two agents is that epinephrine, but not norepinephrine, has a beta 2 agonist effect. And what is the result of this difference in clinical practice? This is a very interesting Optima-CC trial, including only 57 patients, but there is a reason about this small sample size. And patients had post myocardial infarction, cardiogenic shock, and the authors evaluated compared norepinephrine versus epinephrine as first-line therapy, and the primary outcome was hemodynamic effects of epinephrine, increase in cardiac index. And as you can see, this is an important point. All patients, almost 70% of patients in both groups received dobutamine at low doses as inotropic agents. So first, what about hemodynamic effects between groups? So the blue curve represents patients receiving epinephrine, and the red curves represent patients receiving norepinephrine. As you can see, there was no difference between groups in terms of mean arterial pressure, but there was a transient difference in terms of cardiac output with an increase with a higher cardiac output in patients receiving epinephrine. What are the reasons of this higher cardiac output? That was not due to higher contractility. As you can see, because stroke volume was not different between groups, but this was due to the higher heart rate induced by epinephrine administration. So the famous cardiac side effects with arrhythmias. What about other outcomes? The double product, which is heart rate times systolic arterial pressure, and which is a surrogate of myocardial work, was increased in the epinephrine group, and also blood lactate concentration was higher in the epinephrine group compared to norepinephrine group. Okay, but we already know that epinephrine administration is associated with higher blood lactate concentration because of this beta 2 effect, and that epinephrine administration is also associated with higher tachycardia. But what is more important in this study is that the trial was prematurely stopped because the proportion of patients with refractory shock was significantly higher in the epinephrine group than in the norepinephrine group. And of course, this is only the results of the Optima-CC, which is a small randomized trial. But if we look at the different at the results of the meta-analysis, including all the different studies and the Optima-CC results, comparing the use of epinephrine and norepinephrine in patients with cardiogenic shock, what we can see in this graph is that there is a clear association between the proportion of patients treated with epinephrine and the proportion of patients who died, meaning that the use of epinephrine is associated with worse patient outcomes. And that's the reason why, as dopamine, epinephrine is no longer recommended to date as inotropic agents, if possible, in patients with cardiogenic shock. There are still two other agents with inotropic property, Levosimendan and milrinone. And if we look at the results once again of the ESICM Endurance International Survey, we can see that such drugs are not really very frequently used in among European intensivists. Only half of intensivists regarding levosimendan and 60% of respondents regarding milrinone, which is phosphodiesterase inhibitor. So, what are the differences of these two agents compared to adrenergic agents such as norepinephrine, epinephrine, or dobutamine? So the main important point is that levosimendan, as milrinone, does not use adrenergic intracellular pathway to exert their effects. how levosimendan is working. This is a calcium synthesizer, meaning that it improves this, it facilitates the interaction between calcium and the actin and troponin, actin and myosin microfilaments. So if we want to summarize the effects of levosimendan, it is an inotropic agent, but levosimendan also exerts vasodilation, arterial vasodilation, meaning that this is an inodilator, such as dobutamine, associating a vasodilatator effect plus an inotrope effect. And levosimendan may also be interesting in terms of cardioprotection effects because of its mitochondrial effects compared to dobutamine, which has a very short half-life. The levosimendan half-life is very prolonged with a prolonged inotropic effect for 1 to 2 weeks. And as it does not use the beta-adrenergic signaling pathway, it could be interesting and it may be effective in patients on beta blockers. What about the use of levosimendan in patients with cardiogenic shock in the existing literature? There are only two randomized trials. The first one is a survival trial comparing levosimendan to dobutamine in more than 1,000 patients, not with cardiogenic shock, but with acute heart failure, and there was no difference in terms of all-cause mortality at 180 days between the two groups of patients. Nevertheless, as you can see in this graph, the drop in B-natural peptide was higher in levosimendan group than in the dobutamine group, but it's not very clinically relevant. And the conclusion of this paper was that there was also higher incidences of atrial fibrillation, hypokalemia, and headache in the levosimendan group. The second randomized trial is Cheetah trial, less than 1,000 patients, also with acute heart failure, but after cardiac surgery. So this is focused on surgical patients. Once again, levosimendan was compared as dobutamine, and once again, there was no difference in terms of 30-day mortality rate between the two groups of patients, with a premature and the study was prematurely terminated for futility after including 500 patients. And if we look at the potential side effects between the two groups, there was once again no significant difference between the levosimendan group and the placebo group in rates of hypertension or cardiac arrhythmia. So two randomized studies, two negative randomized studies in medical and surgical patients with acute heart failure. That's the reason why, if this is the conclusion of a position paper, by Bernard Chollet, of the use, the potential indications of levosimendan in critically ill patients. First, there is maybe an indication of levosimendan in decompensated heart failure in patients receiving beta blockers. Maybe there is also an indication of repeated infusion of levosimendan in patients with terminal heart failure awaiting heart transplantation or LVAD. What about the other groups of patients? Maybe indication for patients with AV failure, with pulmonary hypertension, but low level of evidence. Cardiogenic shock, which is the topic of this lecture. As you can see, there is no evidence. This is only maybe. Takotsubo, maybe. Winning from ECMO, but this is outside, beyond this. This is outside the scope of this lecture. Maybe, but what is sure that is there is no indication of levosimendan for the prevention of low cardiac output syndrome following cardiac surgery in patients with low left ventricular ejection fraction. And there is no indication for levosimendan in the general cardiac surgery population. So as you can see, levosimendan to date is not a very popular inotropic agent in patients with cardiogenic shock. So what about milrinone? Milrinone, which is a phosphodiesterase 3 inhibitor that increases cardiac inotropy, lusitropy, and also induces peripheral vasodilation. So milrinone, as dobutamine, as levosimendan, is an inodilator, meaning that it combines vasodilatator activity plus inotrope property. And there is only one randomized trial comparing the effect of milrinone versus dobutamine in patients with cardiogenic shock. This is a DOREMI trial. Less than 200 patients with admitted to cardiac ICU with cardiogenic shock were included, and the primary endpoint was in-hospital death from any cause, stroke or cardiovascular or renal events. And as we can see on this graphical abstract, there was no difference between group in terms of primary composite outcome or in important secondary outcomes. So there is no evidence of efficiency of milrinone and levosimendan in patients with cardiogenic shock, but we know that we have a price to pay when we want to administer such drugs. For levosimendan, this is arterial hypotension, atrial and ventricular tachyarrhythmias and headaches. And for milrinone, this is tachyarrhythmias and arterial hypotension as well. So what are the current recommendations about the use of these two inotrope agents? Levosimendan or type 3 phosphodiesterase inhibitors, meaning milrinone, may be preferred over dobutamine for patients on beta blockers as they act through independent mechanisms. And I think that there is absolutely no other indication for using levosimendan or milrinone in patients with cardiogenic shock to date. Okay, I think that the overview about patients with cardiogenic shock is now over, and we have to move to the second situation, which is septic shock. Because, of course, septic shock is, first of all, a vasoprediction, and we have to control the source of infection. We agree, but you also know that uh, some patients with septic shock may experience cardiac dysfunction. What I want to say just before discussing inotropic agents in patients with septic shock is that we can discuss about the hemodynamic management of patients with septic shock as long as we want. But if we do not administer antibiotics, early antibiotics, if we do not control the source of infection in such patients, we can be sure that they will die. And finally, hemodynamic management is only the second step of management of patients with septic shock. Okay, that being said, when inotropes should be administered in patients with septic shock? Only in patients who have also LV dysfunction. If there is no LV dysfunction, there is no indication of administering inotropes agents in patients with septic shock. And this has been nicely demonstrated years and years ago, decades ago, by Natalie Eyes and Luciano Gattinoni with these two trials which have been published in the New England Journal of Medicine. In these two trials, the authors tried to increase, to supra-maximize the cardiac outputs, to increase the oxygen delivery in patients with septic shock without LV dysfunction. And what they observed in both trials is that that patient outcomes was poorer in the group of patients receiving dobutamine than in the group of patients receiving placebo. Why? Because of the side effects of dobutamine, and there is absolutely no physiological reasons to supra-maximize, to increase oxygen delivery in patients without LV dysfunction. All right, so it means that we have to consider inotropes only in patients with septic shock and LV dysfunction. In other words, in patients with sepsis-induced cardiomyopathy, which is which has a very complex pathophysiology and which concerns from 20 to 60% of patients with cardiogenic shock. And when we look at the Surviving Sepsis Campaign recommendation about the use of inotrope agent, it is clearly stated that if cardiac dysfunction with persistent hypoperfusion is present, despite adequate volume status and blood pressure, so we have to consider the administration of inotrope agents. But which inotropes should be administered? And there is a choice between adding dobutamine to norepinephrine or to switch for epinephrine administration. And there are some data in the literature about the CATS trial, which is very interesting, but interesting a randomized trial comparing epinephrine versus norepinephrine plus dobutamine in patients with septic shock, and the primary endpoint was a 28-day all-cause mortality. And what was observed by the author is that there was absolutely no difference in terms of outcomes and mortality between the two groups of patients. If we want to consider secondary outcomes, no difference between groups in terms of vasopressor withdrawal, but no difference in terms of ICU loss, of hospital length of stay, of pressor-free days, or ventilatory-free days until days 28 or days 90. But between the two groups, there was only metabolic differences, meaning that patients receiving epinephrine had higher blood lactate concentration at D1 and therefore lower arterial pH. So once again, no difference in terms of efficiency between epinephrine and norepinephrine plus dobutamine, but metabolic side effects of epinephrine were observed in this randomized trial. And when we look at the results of meta-analysis, including all the different studies comparing the use of epinephrine in patients with septic shock, as you can see, there was absolutely no difference in terms of mortality between epinephrine and norepinephrine plus dobutamine. So there is no proven superiority of dobutamine plus norepinephrine versus epinephrine. And how can we choose between these two strategies? The first one being adding dobutamine to norepinephrine, and the second one being to switch for administration of epinephrine. So your choice should be based on the side effects of the different agents and of the availability of the agent, because in Europe, for sure, it's very easy to consider dobutamine because dobutamine is available for in all ICUs in Europe, but it's not the case in some countries worldwide, and especially in countries with low income level. And therefore, in such countries, maybe epinephrine should be considered if dobutamine is not available. And when we come back to the surviving sepsis campaign recommendation, yes, if cardiac dysfunction is associated with persistent hypoperfusion, we have to consider adding dobutamine or switching to epinephrine. And what is the value of administering dobutamine in patients with sepsis-induced cardiomyopathy? This is still debating. This is still a current open question, and there is an ongoing trial, which is the ADAPT trial, in which the authors aim at comparing the effects of dobutamine versus placebo in terms of patient outcomes. I know that recruitment is now over, and we are waiting for the results of this study, and I hope that preliminary results will be presented in the future ESICM Congress in October in Germany. So, when inotropes should be administered in patients with LV dysfunction, and you can choose between adding dobutamine to norepinephrine or to switch for epinephrine. And of course, VA ECMO should be considered in the more severe patients. But once again, VA ECMO is beyond the scope of this lecture, and I don't want to discuss about this point. What about alternative treatments? There are many evolving concepts in the management of patients with septic shock, and regarding inotropes, there is an evolving concept with the use of inodilator to optimize tissue perfusion. And when we talk about inodilator, we talk about levosimendan or we talk about milrinone. The use of levosimendan has been tested in patients with septic shock. This is the Leopard study. And as you can see, all patients received norepinephrine before randomization only a small part of patients received epinephrine, and more interesting, only a few patients, very few patients, received dobutamine before randomization, meaning that only a very few patients had LV dysfunction before receiving placebo or levosimendan. And but that was maybe expected. There was no difference in terms of outcomes and survival between the two groups of patients, and no difference in terms of survival, no difference in terms of primary outcome, which was changes in daily SOFA score, but uh, the need to increase the doses of norepinephrine in the levosimendan group and more arrhythmias, cardiac arrhythmias in the levosimendan group. I said that probably it was expected result because as the vast majority of patients did not have LV dysfunction. It means that many patients without any LV dysfunction received levosimendan, so received inotropes while they did not need inotropes. That's the reason why there is no beneficial effect, but only side effects with levosimendan. And years later, subgroup analysis, post-hoc analysis of LEOPARD study has been performed, focusing on patients with biomarkers of cardiac injury, meaning focusing on patients with increased blood troponin or natural peptide concentration. And as you can see, there was no difference between the group between the two groups of patients, between levosimendan and placebo, even in patients with evidence of cardiac injury, as illustrated by increased blood troponin or natural peptide concentration. And this is true for changes in SOFA score, but this is also true in terms of mortality at day 28. If we look at the results of a meta-analysis including 7 randomized trials, but which did not include the LEOPARD study, there was no difference in terms of mortality, and there was no difference in terms of ICU length of stay between levosimendan and dobutamine. And that's the reason why current recommendations are against using levosimendan in patients with septic shock. So if we come back to the position paper by Bernard Chollet, is there any indication for levosimendan in patients with septic shock? Maybe in terms of prevention of organ dysfunction, the response is very clear, no. But what is interesting is that when you consider whatever the drugs with positive chronotropic effects you consider in patients with septic shock, dopamine, levosimendan, epinephrine, you can see that the use of inotropic agents in patients with septic shock is associated with increased mortality. And for sure, because it's obviously that it's that patients who have sepsis-induced cardiomyopathy are more severe than patients without sepsis-induced cardiomyopathy. So to summarize, absolutely no place for levosimendan to date in patients with septic shock. What about milrinone? So I cannot answer to this question because there are no studies about the use of milrinone in patients with septic shock. And there are, I think that the use of such inotropes agents in patients with septic shock represents the future of research areas and the future research directions in these patients. To conclude about inotropes agents, two situations, cardiogenic shock and septic shock. In both situations, the first line inotropes should be dobutamine. In patients with cardiogenic shock, levosimendan or milrinone or other phosphodiesterase inhibitors should be considered only in patients with chronic medication by beta blockers agent, as levosimendan and phosphodiesterase inhibitor exert their effects through different mechanisms than adrenergic pathways. Regarding septic shock, dobutamine should be the first line inotrope, or if dobutamine is not available, epinephrine can be considered. And there is today absolutely no indication for levosimendan or milrinone, even in patients receiving chronic medication by beta blockers agents. Thank you very much for your attention.
Thank you, Professor Jozwiak, sir. That was very nice and very elaborate. So, can you please stop the share screen?
Yeah, sure.
So, I request the audience if they have any questions, please type in their questions. So maybe we can just discuss a few points, sir, which will be of interest to everybody. So you mentioned so a lot of things I'm going to ask. You already mentioned, maybe in a few details you can say a little more. So first was about the use of norepinephrine and dobutamine in cardiogenic shock. So do we always start both together, or is there a situation where you might start noradrenaline first or dobutamine first?
Okay, in patients with cardiogenic shock.
Yes.
Okay, in patient with cardiogenic. So this is my clinical practice. You know, when patients are admitted to ICU for cardiogenic shock, they are admitted because of shock. So meaning because of low arterial hypotension. So the first step is to administer fluids, even in patients with cardiogenic shock, except in patients with cardiogenic shock and pulmonary edema, you know. But first we administer fluids and we start very early norepinephrine administration. And after we perform an echocardiography, we can see that the main cause of shock is probably left ventricular contractility impairment, so cardiogenic shock. And in a second step, we will administer dobutamine only if it is not possible to correct shock states with norepinephrine alone, meaning that we start to administer norepinephrine, and after we monitor blood lactate concentration, we monitor PCO2 gap, we monitor SCVO2, and if we can see that SCVO2 increases, the PCO2 gap decreases, that there is a good lactate clearance, that skin mottlings or disappears, and that CRT is corrected with norepinephrine alone. We do not add dobutamine. But of course, if under norepinephrine alone, skin motors persists, oliguria persists, hyperlactatemia persists, and so on and so on, we will add dobutamine as inotrope agent in a second step.
Yeah. Thank you for the answer, sir. Then milrinone and dobutamine. So you showed that obviously milrinone has an advantage if the patient is on beta blockers or has been on beta blockers recently. So are there any other conditions where you may choose one over the other?
To my knowledge, there is no other indication. To be very honest and clear with you, we do not use milrinone in my unit. We do not use milrinone in France, right? And we use, but in very, very few and very selected patients, levosimendan, meaning that we consider administering levosimendan only in patients receiving beta blockers medication and in whom dobutamine is not working. Why? Because we know that dobutamine has a very short half-life, meaning that if you want to stop dobutamine, a few minutes later, there is no longer dobutamine into your patient, and this is very, in case of side effects, it's very easy to prevent them and to treat them. But levosimendan has a very long half-life, and which lasts between 1 and 2 weeks. So if after administering Levosimendan, and if you have some side effects, you can do nothing else. You have just to wait that the effects of Levosimendan stop. And if you have to wait for 1 or 2 weeks, it can be a little bit too long for your patients. That's the reason why we are very cautious with the use of Levosimendan, and we use it only in a very selected patients with persistent low LV contractility who needs to receive very high doses of dobutamine because of their beta blockers as a medical chronication, as a chronic medication.
Thank you, sir. So about just talking about levosimendan, so some of the trials showed increased arrhythmias, atrial fibrillation especially. So it is
Yeah.
not a catecholamine increasing drug. So any mechanism was ascribed to this? Why arrhythmias increased with levosimendan?
Oh, you mean why? What is the pathophysiology of cardiac arrhythmias induced by levosimendan?
Yeah, what is the pathophysiology for levosimendan induced cardiac arrhythmia?
Because the administration of levosimendan induces an increase in calcium concentration into the cytoplasm of cardiomyocyte, and there is an overload of calcium into cells. That's the reason why it could induce it may induce more arrhythmias than norepinephrine or than dobutamine, for example.
Right, sir. So then about septic cardiomyopathy. So you showed that there has been some work and both epinephrine alone or dobutamine and epinephrine have equivalent results. But at the same time, myocardial cut ischemia and lactate increases more with epinephrine. So these are some problems. But you showed results were by and large similar, and that is what the sepsis guidelines also says, that you can use epinephrine instead of dobutamine and norepinephrine. But the only other thing about epinephrine is its effect with differing doses. At a lower dose, it is beta 1, beta 2, but as you go up, the alpha effect also comes in. Right? So, when you have septic shock going on, there is also hypotension. So, what kind of dose should you use? You should just titrate it or what?
You are right that the effects of epinephrine are dose dependent. Um, we do not use epinephrine in my unit. We do not use epinephrine in France because because there are there's a lot of reasons in the existing literature regarding microcirculation, Plancking microcirculation, but also the proportion of patients with refractory shock in the Optima SSA study, even if we consider and we are discussing about patients with septic shock. And my opinion is that we have to favor norepinephrine plus dobutamine over epinephrine in patients with cardiogenic shock for sure, and even in patients with septic shock. Um, it's very difficult, to recommend doses of epinephrine because you have to adapt doses of epinephrine to the mean arterial pressure of your patient and to the cardiac index of your patient associated with signs of tissue hypoxia. And it's very difficult to predict how your patient will respond. And when you administer epinephrine, you do not know if you correct more uh, the vasoplasia or more the cardiac dysfunction. And it's I don't know how to titrate my epinephrine because it's not possible to titrate either or your on your mean arterial pressure level or on your cardiac function. And that's the reason why I prefer at the bedside to use norepinephrine plus dobutamine, because if you want to favor pressure and perfusion, so you have to titrate your norepinephrine dose. But if you want to favor or to correct your cardiac dysfunction, you have to titrate dobutamine dose. And it's possible to titrate differently the vasopressor activity and the inotrope activity with association of norepinephrine and dobutamine, which is not possible when you use epinephrine alone. So for sure, if you are working in a country where dobutamine is not available, you have to consider epinephrine. But it's very difficult to find the minimum efficient dose of epinephrine because you cannot differentiate the vasopressor effect and the inotrope effect of epinephrine.
Thank you, sir. So just last couple of questions. One is we didn't talk about VECMO, but maybe you can just touch upon it. So in VA ECMO, the EF is low. So is there a preference for the inotrope here to kind of improve the ejection?
In patients requiring ECMO?
Yeah, VA ECMO. Yeah, VA ECMO. Yeah.
So you mean patients with a septic shock, for example, or cardiogenic shock, requiring VA ECMO, if you have to continue inotrope in these patients?
Yeah, if you're using any inotropic support in these patients, is there a preference?
Okay. You know that in France, this is a stepwise approach, meaning that your patients require inotropes, whatever the inotropes agents you want to favor. And if it does not work or it is not sufficient, you have to go to the next step, which is VA ECMO. And it's quite rare that patients with under VA ECMO also require the administration of inotrope agents. And I think that we have to consider inotrope agents not in patients under VA ECMO, but for the winning of VA ECMO. And there are a lot of data in the existing literature regarding the potential beneficial effects of Levosimendan for the winning of VA ECMO because of the long half-life of Levosimendan. And in practice, your patient receive I don't know, dobutamine, for example, but you need to put a VA ECMO. So that after you have the VA ECMO, you stop dobutamine. You have to wait until recovery of cardiac function. And when you ask about the winning of VA ECMO, in that case and at that moment, we can maybe discuss to administer inotropes to facilitate the winning of VA ECMO. And in that case, levosimendan may be an interesting option.
Thank you. Just the last question. So you showed this drug enoximon. So enoximon, is it being used in France? Does it have any special properties? We don't use it.
We do not use enoximon as we did not use milrinone because it's very expensive. The half-life is very long, and it induces a very marked arterial hypotension.
Right, sir. So thank you, Professor Jozwiak, sir. That was wonderful, very educative, and we had a lovely audience. And soon we shall put it up on our channel. Thank you very much, sir. Goodbye. Take care.
Thank you for your invitation. It was my pleasure to be with you. So have a nice evening. Bye bye.
Bye bye. I thank the audience for their patient hearing. Thank you very much. Thank you, sir. Bye bye.